All right, I invite our panelists to make their way back to the screens. All right. Good afternoon, everyone. My name is Amber Scott, and I am the Director of Communications for Salvation and Social Justice. It's such a pleasure to see you all here on this evening. Congratulations on almost making it through another week. Happy Friday Eve. And it's a pleasure to be here with you to celebrate and share in this new healthcare report that Salvation and Social Justice just recently released. The title of the report is Break Every Chain from Cradle to COVID-19. And we truly hope that this report is robust, that it's informative, and that it reveals the deep-seated racism throughout our healthcare system. This is really why we are calling for a Black health revolution. Tonight, you will hear remarks from our founder and executive director, Reverend Dr. Charles Boyer. Following him, we will hear from our colleague, Sister Crystal Charlie Sibley, who is the Black Health Equity Director here at Salvation and Social Justice. And then we will hear from our illustrious panelists. Tonight, we are blessed to have Sister Lisa Asare, the Deputy Commissioner at New Jersey Department of Health. We have Melissa Fox, who is the Chief Operating Officer at Ascenda Integrated Health. And we have Dr. Jerry Harris, who's the chair of the Salvation and Social Justice Board of Directors, as well as the chair emeritus of the Black Issues Convention. And after that, the bulk of our conversation will be dedicated to Q&A. So as we start hearing from Reverend Dr. Boyer and Sister Crystal and our panelists, I invite you to start inserting any questions or thoughts or feedback that you may have into the chat portion. And then at the end of the conversation, we will dedicate time to hearing from you all, the audience. So at this time, I turn it over to Reverend Boyer.
Thank you, Crystal, and thank you everyone who is joining us this afternoon. Grateful for everyone. I just want to take a few seconds to give a tremendous amount of thanks to the Salvation and Social Justice team, who put a tremendous amount of work into this, to our legal support, to our legal partners, which did a tremendous amount of deep dive into the history and into the work and the data. This would not be possible without our legal scholars' help. A tremendous amount of thanks to such a great board of directors, board of trustees who have weighed in very heavily and brought both their expertise and institutional knowledge to really bring this report to not only shape it, but to also make sure that it ties in to the history and into the long work, justice work, healthcare related in New Jersey. So I want to take a moment to give a major thanks and gratitude to our chair, Jerome Harris, and certainly to the one and only Clara Gregory, our vice chair, who put tremendous amount of work into this report. And so our new report entitled Break Every Chain from Cradle to COVID-19, this report is really here to educate and highlight how racism operates in New Jersey's healthcare system. And it looks to bring justice into action. So New Jersey's 2010, 2020, and now 2030 health plan includes the goal of reducing health disparities in our state. But the outcome for Black New Jerseyans continues to be profoundly disproportionate, as documented by the Department of Health. Healthcare must be made accessible, and it must be a human right to all New Jerseyans immediately. The COVID-19 epidemic has shown without a doubt the vast inequities in our system and highlights and brings about a sense of urgency more than ever, creates a moral mandate as to why healthcare should be a human right. One of the major issues it ought to be is because so many of the frontline service workers, folks on the front line in our healthcare systems, our delivery services, our warehouse, our food service, our child workers, all the folks who make life comfortable for the elite, for all of us who can work home, for all the folks in the upper echelon, who all of a sudden became essential workers, but not essential enough for us to make sure they have healthcare coverage. This is why healthcare is a moral and racial justice imperative. In New Jersey, Black residents, somewhere 16% of the population, but 21% of the state's fatalities due to COVID. We're in a Lazarus moment. In New Jersey, as the entombment of slavery is shattered, we find now the command to live into this liberation call, one that is birth of a collective liberation, a collective prophetic call to live as it relates to healthcare. And it requires the government and public systems to transform away from a systemic, monetized market into one that is about compassion, care, and healthcare as a human right. We must shed the grave clothes which have destined many Black bodies to death. And so with that, I am so excited tonight to introduce our leader in this space, a woman of great background, integrity, and the right leader for this work, the Director of Black Health Equity for Salvation and Social Justice, Crystal Charlie Sibley.
Thank you, Reverend Boyer, and thank you, Amber. I am very excited to be here to talk about this topic of healthcare as a human right. I just want to kind of take some time to put out what the prophetic demands are from salvation and social justice. I think that obviously Reverend Boyer put the framework out there for why we are here today and all of the disparities and equities that currently exist and how they are transforming the lives of Black and Brown people in the state of New Jersey. And we're here to combat that. And so I want to just run through these so that you know where we're going with this and what it is that we seek out of this call to action. Number one, we wish to enact universal health care immediately. Number two, prioritize Black maternal health. Number three, integrate healthcare. The Office for Civil Rights must enforce Title VI compliance. Number four, divest from militarization and criminalization and invest in mental health care and community wellness. Number 5, transform the use of healthcare to include social determinants. Number 6, adequately fund and empower the Office of Minority and Multicultural Health. Number 7, establish adequate, accessible, preventable care in Black communities. And number 8, mandate racial impact statements for all healthcare legislation. Number 9, provide accessible testing centers. And number 10, ensure uniform methods of data collection. The data and these ideals are reflective of pervasive forms of inequality and injustice in New Jersey's healthcare system. We must fight to combat these injustices. Reverend Dr. Martin Luther King Jr.'s quote is saying, all forms of inequality, injustice in healthcare is the most shocking and the most inhumane. Today, we break every chain. This is the Black healthcare revolution. Amber?
All right, thank you, Sister Crystal. So at this time, we would love to hear from each of our panelists. We have, like we introduced earlier, Dr. Jerry Harris, Sister Melissa Fox, Sister Lisa Asare. So at this time, I turn it over to each of you to just give your initial thoughts on this moment that we are in.
Good afternoon.
Dr. Harris. Yeah.
Good afternoon. My name is Jerry Harris. I am have the pleasure. It is a really rewarding pleasure to serve as chairperson of the Salvation and Social Justice Board. It's been repeated over and over again that the ruin of a nation begins in its homes of its people. Black people in New Jersey are fundamentally dying. Our people are dying. And we're dying, as folks have commented already on, from disparate health outcomes, conditions that exist that don't necessarily have to. Was excited to join this panel because some 30 more years ago, I was part of a group of Black professionals who formed this steering committee on the state of Black health in partnership with the then Assembly Appropriations Chair, John Watson. Were able to secure an appropriation that went into the Department of Health's budget and to convene in 1989 the first ever Black Summit on Black and minority health. Pursuant, that conference was called in part in reaction to the HHS Secretary's report that was issued in 1985, but for the first time documented the disparate outcomes. Black people had been experiencing them. We knew they were there, but in 1985, they were documented. Coming out of that conference was a series of requests, demands, if you will, that went to the then governor, Jim Florio, who was elected in 1989, to create a commission on the state of Black health and to create the Office of Minority Health. Since then, the struggle has continued. And COVID-19 and the data that we see tells us today that there's much that needs to be done. I'm delighted to be part of the conversation so we can get to go to work.
Thank you. Thank you. Sister Melissa Fox.
Yes, thank you. And thank you to Salvation and Social Justice for having me here this evening to talk about this very important topic. You know, I've been in healthcare for, a couple of decades now. And, one of the things that really jumps out to me as I hear about this report and read the statistics contained within, that we shouldn't still be fighting this battle. This should not be something that has to require a fight. This should be something that all like-minded people who are concerned about the welfare of our families, who are concerned about the welfare of our communities, who are concerned about the future of our state, that are all on board saying, let's unplug, unpack, and turn over every stone to get this resolved. Because if we have a segment of our population, in this case, the Black population, that is dying at disproportionate rates, from various maladies, illnesses, and I understand that this is not unique to New Jersey. This is national. But in our state, if we are seeing that, then we understand that there is a need to have all hands on deck in no uncertain terms to be able to move these conversations forward and to enact actions to improve it. when I worked in, one of the places that I worked previously to coming to Ascenda, I was, ran a network of health centers. And, every now and then I got the opportunity to go in and talk to some of the patients and just kind of, see how they were doing. And, one day I talked to this young woman, and she said to me, this young Black woman, she said to me, until I came here, she said, I was never treated as well as when I came here to this health center. And at the time, that struck me to my core, because when folks are going to get healthcare, when they are coming to us to get these supports, be it physical health, mental health, whatever it looks like, they are at a point where they are extremely vulnerable. They're at a point when they are in pain. Someone who they love is in pain. And so if they're coming into these settings looking to get support, and they are met with bias, and they're met with disregard because of their skin color, that cannot be accepted. And that should not have been something that I heard from this young woman, that the first time she came into this health center, that was the first time in a healthcare setting that she felt treated with respect. So I applaud Salvation and Social Justice for moving this conversation forward for our state. I look forward to being engaged in any of these conversations as we move forward.
Wonderful. Dynamic as always. Thank you, Melissa. And then last but not least, I turn it over to Sister Lisa Asari.
Thank you. And good evening, everyone. Thanks for having me here. My name is Lisa Asari, and I work as the Assistant Commissioner in the Division of Family Health Services at the New Jersey Department of Health. I've been there for a minute. It's probably been about 23 years. And I say that because I think that I've seen some things change over time. So I first came to the department and worked in the Center for Health Statistics. And at that time, we were working on Healthy New Jersey 2000. The impetus was really to reduce disparities. It was really to reduce disparities. Then we got into years past, we got into 2010, and we got a little bolder, and it was about eliminating disparities. And then it still wasn't enough. And where we are now, we're really talking about health equity and really beginning to talk about anti-racism. And I think it's time. It's past time, actually, it's overdue. So really thrilled to be here with Salvation and Social Justice to talk about these issues. When I heard about some of the priorities and some of the things the prophetic asks, prioritize maternal health is the work that I do. Addressing social determinants of health is key and critical. I wish it was just about healthcare and access to healthcare, but it's not. They say about 30% of people's outcomes is related to healthcare, and the other 70% is related to all of those social determinants of health. So things like housing, employment, education, transportation, so on and so forth. And so I think when we think about these solutions, we really have to come to them from a very holistic perspective. It's not enough to give somebody access to healthcare or checkup. They need a job too. And so I will talk a little bit later on about some of the things that we're doing in my division, where we're really partnering more with non-traditional health partners than health partners, because we realize and recognize that we have to partner with the Department of Labor and Workforce Development to create jobs for folks, because they're not listening to me coming to talk about breastfeeding or WIC when they can't pay the rent. And so I think the approach we're taking is much more holistic. I will talk about the things we're doing specifically in maternal health. It is a priority in New Jersey, and Black maternal health is the priority because of the disparities that have been described. And then I will also talk about some of the really pioneering work we're doing with community health workers that really takes them through certification, demands a livable wage for them, and so on and so forth. So really excited to be here. Happy that I align with the priorities of Salvation and Social Justice, and really excited to get into the conversation. Thank you.
Yes, thank you. I am excited. So we are about to get into the nitty gritty of it. It was great to hear these initial reflections. There's a lot to unpack out of everything that our three panelists just shared, as well as the report itself. Is a long 25, 26-page document. So there's a lot of content there. So now I'm going to turn it over to Crystal to lead us through some initial questions that she prepared. And then after Crystal gets through those questions, we will then open it up to the larger community present to chime in with any questions that they may have. While we're going through the initial questions, please use the chat function if you have something that comes to your mind right now. We want to make sure we don't lose it. So I invite you to use the chat function as we're doing this part of the discussion. Crystal?
Yes, thank you so much, Amber. And thank you once again to all of our panelists who thought it not robbery for being with us this evening. We are going to do our best to cover as much from A to Z of that 26-page document to really get into the nitty-gritty and address these issues. So tonight we are gathered this evening virtually as a matter of health precautions. Scientists certainly have warned us that in-person convening at this time can literally be a matter of life or death. The novel coronavirus, also known as COVID-19, is taking its toll on America. And undoubtedly, the virus is ravaging Black America. As reported by NJ.com, although Black residents compose 14% of the state's population, we represent 21.3% of the state's fatalities due to COVID-19. Mr. Harris, can you please provide some insight on the devastating effects of COVID-19, particularly on the Black community here in New Jersey?
Well, when we talk about excess death, and I said earlier that our people are dying, we think that our people are dying at twice the rate of white people as a result of COVID. We think about the fact that our people are 3 times as likely in New Jersey to be tested positive. And to think about the fact that no matter what your income level, no matter where you live in South Jersey or North Jersey, right, you are likely, if you are African descendant, to have some difficulty actually getting to having access to healthcare, quality healthcare. The fundamental reality that as a consequence of our people being, as was reported earlier, essential workers, we're winding up having to go to work. We're taking the trains. We can't do social distancing. And we live in communities where there's high density and crowding. There's not room for social distancing. All those factors contribute. So the intersection of the social determinants of health are clearly there. What is interesting, I think, also is the state's reaction to it. And I just want to spend a couple of seconds talking about this. The Legislative Black Caucus and the United Black Agenda from the outset of the pandemic in New Jersey have been trying to identify actions, policy actions that could be taken at the state level. So early on, a recommendation was made to establish a task force on COVID-19 at the governor's level, interdepartmental task force. That has not moved. Recommendation to establish a racial equity COVID-19 czar has been recommended. That has not moved. The legislation to establish, require what's recommended in the report in terms of racial equity assessment, evaluations of legislation has not moved. And frankly, the recommendation, and I think as Assemblywoman McKnight from Hudson County has proposed a piece of legislation that would declare racism a public health crisis. That has not moved. So the notion of having disparate impact, number of African American businesses having declined, people being evicted from their homes, stress, increased domestic violence, all these things are a result of COVID, but it is, in fact, institutional racism that has existed in the healthcare field for a long time, impacting our community.
Absolutely, absolutely. As we know, health is impacted by all of the systems of our lives. Black residents who are living in poverty are more likely to be exposed to environmental hazards, including air pollution, lead contamination, less likely to be the recipients of remediation for environmental disasters or climate crisis, despite often being on the front line. So here we are again, we're back at the front lines, and we are on the short end of the stick. So with respect to social determinants of health, nutrition, housing, and air quality. Can you shed some light on the long-term and early impact of systemic racism? Talks about how we got here.
Well, interesting. 2019 marked 400 years of the arrival of the first enslaved Africans in English North America. Okay. It was interesting to me. I was playing with numbers. 2019 marked 30 years after the first State of Black Health Summit. And in many ways, in the area of health, we haven't moved very far. Health quality of what we know about providing services, what do we know about technology, the application has moved, but we have, as a people, we have not benefited from that. I think it's important because when we talk sometimes about systemic racism, people don't have a clear definition. So the intersection of overlapping codependent racist institutions, policies and practices, behaviors that give unjust amount of resources, rights, and power to white people while denying them to people of color, right? So if we are to accomplish, to intervene, if you will, as you guys suggest, have a revolution. Revolution seems to be is a noun. Revolt is what kind of comes to mind. But as I'm hoping, as Gil Scott Heron said, this revolution will not be televised, all right, but it will happen as a consequence of our moving forward. But in order to really impact those social determinants, you have to go system by system, right? If we have more people trained and working effectively in healthcare and delivering, that may mean there's more stability in homes. If there's more stability in homes, there may be more better nutrition. If there's less stress, then the likelihood that a baby will not go to full term is more likely. So there's this interlocking kind of system between, or relationship between, healthcare disparities, social determinants of health, and systemic racism at work. And we can't talk about, they talk about unemployment being 7% down to 7% nationally. Well, unemployment statistics properly described in the Black community is 12.7%. But there are other people who suggest that the real unemployment rate in the Black community is 30.4%. And if that's the living reality, the difference between the living reality and the statistical reality has to be addressed and moved on directly. So dismantling this system is what the revolution is about, and it's going to take work from all the people represented on this panel and those in the audience as well.
Thank you so much, Mr. Harris. And my hope is that the revolution will be televised. That is why we're here live. We're here on your social media feed. We're going to televise this revolution, and we're going to keep chipping away at it until we have defeated it. So I want to talk about the report from historical context. During the Civil Rights era, activists fought to desegregate America's largely white social and political institutions. In the wake of Brown versus Board of Education, a landmark Supreme Court case that ruled segregation in public schools unconstitutional, Black physicians and attorneys led a campaign to expand those desegregation efforts. It would be a decade later when Congress passed Title VI of the Civil Rights Act of 1964, which prohibited discrimination based on race or national origin in any program or organization that received federal funding. The first test of Title VI enforcement came in 1965 when Medicare, a federally funded insurance program, was signed into law. However, there was little oversight for compliance in other healthcare spaces outside of hospitals. Knowing this history and the overall deficiencies in access to quality healthcare, Mrs. Fox, can you please share with us how in the integrated healthcare, what's their model of care and how they work to close the gaps in inequitable access to quality healthcare?
Yes, thank you. So let me just first say, listening to Mr. Harris, as a student of history myself, I appreciated everything that you were laying out and the complexity of this issue. And when we talk about the racist, systemic racism that exists and that contributes to healthcare, that everybody understands that it doesn't stop at the door of healthcare, nor does it start there. So when we are talking about how to address it, and this goes to your question, Crystal, in terms of an integrated approach, that it really does have to be looked at through the lens of the social determinants that Lisa was speaking to, that it has to be looking, when you're talking about the maternal mortality rates and you see that it goes across all socioeconomic levels, it's clear that there's something else impacting it there. It's not just because this mother has a certain insurance or she lives in a certain part of town, but that there's something happening on the other side of that healthcare door. So looking at it through the integrated health lens allows us to give a little bit more balance to the issues being presented. So at Ascenda, and I'll just kind of back up a little bit in terms of what we do, Ascenda provides services about in 13 counties right now through New Jersey, and they really do run the gamut in terms of what we do. We have everything from outpatient mental health services, substance use disorder treatment. We provide in-home visitation programming, mobile crisis, psychiatric screening. So it really does provide services that address people who are at their most vulnerable. Now, what we also realize, though, through a good percentage of our programming is that when people come to us, that there are other needs that exist within that family or with that individual. So we need to take a full look at everything that's going on. So we need to be assessing for if there are issues with housing. We need to be assessing for if there need to be connections made to economic supports, financial supports, financial education. We need to be assessing for that, and we do that. So we have a good portion of our program that's prevention programming as well that really connects families in the community and individuals in the community to what they need. So in a broad way, that's what we're doing. Now, when we're talking about the systemic racism that we're all battling and that the folks who come to us are battling, what we have challenged ourselves to do at Ascenda, and this is me in very close partnership with our leadership, including our CEO, Dr. Anthony DeFabio. I mean, we are truly taking a very close look at ourselves and reflecting on what we have done and how we can get even better with not only educating our teams internally and making sure that they have the supports internally to look at things through this lens that helps to eliminate these barriers, but also making sure that we're bringing in voices externally. So we know that we can't be the only voices around the table, people who work for us and work with us, but how do we now engage the communities as part of those conversations as well? So when we're talking about, and that may sound like something that's kind of outside of the scope of healthcare, but it's not. I mean, healthcare is of the community. It's for the community and of the community. So you have to have the community's voice. And when we're talking about systemic racism and identifying those gaps that exist, the barriers to care that exist, the experiences that people are walking into when they're going to the hospitals that make them feel like they can't go there, or they're not welcome, or they're not going to get the medication they need, then we need to hear that. Because when we're seeing them in psychiatric screening, or we're seeing them in mobile crisis, or we're sending folks into their homes to support them, then our teams need to be able to relate to them on a different level, be compassionate on a different level. And that helps to start to break that down. And by no stretch of the imagination are we there yet, Crystal, and I'll just tell you, that's something that has to be a journey. It has to be something that not only are you saying you're going to do, not only do you have a strategic plan towards that you're going to measure yourself against, but that you're also going to hold yourself accountable to that continued movement. Because this started, and Mr. Harris, I'll go back with you here. This started 400 years ago when we stepped foot in this English colony, when from the very first moment, we landed here, or we were stolen and brought here, that there was a systemic effort to put us in a certain place, put us in a certain category that was seen as less. So if the entire system of the country was kind of built around that, not kind of, but was built around that thinking and approach, then you have to believe that that was integrated into many of the systems that we deal with. So our folks have to understand that this is going to be a journey. This is going to be something that takes time, but we have to look at it through all needs, that full lens of an integrated health approach to ensure that nothing is missed as much as possible.
Thank you so much. I mean, listen, you covered everything from A to Z, and you know what? It was clear with integrated healthcare, the most important part of that is that we're breaking down the silos, right? When you put mental health off in one corner, and you put substance abuse off in another corner, and then you put housing needs in another corner, or even domestic abuse in another corner, not having a centralized point of care certainly takes away from what it is we're trying to gain now. And as you said, going back 400 years ago, I mean, there's no better definition of being in silos than being taken from your home country and placed someplace and basically isolated from everything you know, right? And so that whole integrated model of care is completely opposite of working in silos, and that's important. So as we talk about the privatization and how it soared in the healthcare system, simultaneously decades of divesting from public healthcare ensured inequitable and separate healthcare systems. So in keeping with our prophetic demands, we seek to establish once and for all that access to healthcare is a human right with no allowances for inequity or inequality, no haves and have-nots. So in your capacity as Chief Operating Officer, how do you see us getting to that place of health liberation? How do we gain the support of healthcare organizations to make this come to fruition?
Wow. I think it's continued education. And I think it's not just education, but accountability. So there's some organizations who are going to hold themselves accountable, right? There's some organizations who are going to make that commitment to being able to provide those integrated services. And if you can't do it yourself, then you're partnering with the right person who's going to do it, because you want to make sure that your care is patient-centered, not organization-centered, not necessarily money-centered, even though that's important. You got to keep the lights on. But if you make sure that you're patient-centered, then you're going to seek the solutions and seek the interventions that are going to keep that person as well as possible and at the center of their care, the consideration of their care. So part of it is the accountability and the conversations like what we're having today, this consistent messaging in terms of the report, putting the stark realities of the statistics in front of people and then saying, look, this is what we're holding ourselves to. How are you going to meet these plans? How are you going to meet these expectations? You may not be able to meet it in the first 6 months. You might not be able to meet it in the first year, but what will you be doing a year and a half from now? You know, what can you accomplish? Because every healthcare organization is starting from a different point, and every healthcare organization has different financial, restrictions that they're dealing within, resource restrictions that they're dealing within. But it is important, I think, if we're going to move this forward as any healthcare organization, then we should be not only having a plan, not only having a consistent approach, but holding ourselves accountable. Because let me just say this too. Mr. Harris touched on it. This isn't a new conversation. This isn't something that people are just finding out. This is something that exists. The challenge is that there hasn't been anything holding everyone's feet to the fire. There hasn't been anything that has been, something that could be lost if you're not doing it. So if we're now partnering with the payers, if we're now not just the healthcare organization, but the payers, the people who are the funders are now saying, well, you know what, we're also going to be taking a look at this as well. And how are you making sure that you're identifying and eliminating any implicit bias that may exist within your organization? What are the numbers? What does it say in terms of the people who you're serving and their outcomes by demographic? What does it say about your maternal health outcomes? What is it saying about you and your organization in terms of your commitment to this? So I think the plan and the accountability and these conversations that we're having in terms of how people will be held accountable will go far in terms of making that change.
Thank you so much. So we're going to turn our attention now to some of the situations right here that fall under the umbrella of New Jersey Department of Health. And so with that being said, many Black communities lack access to private physician practices, but also have limited or no local preventative care facilities. The culmination of this is that Black people frequently do not receive preventative care, which leads to higher rates of emergent and clinic visits. In fact, 7 out of 10 deaths are caused by often preventable conditions, including heart disease, strokes, diabetes, injuries, or some type of cancer. As the Assistant Commissioner of Family Health Services for the New Jersey Department of Health, Ms. Asari, can you please share with us how the various programs under your department work to mitigate the inadequate preventative care that disproportionately impacts Black communities?
Absolutely. So thank you for that important question. And I will start by saying, access to healthcare is important. And you certainly talked about people missing preventative care. But I have to say, they're stressed out. People are very stressed. And I think, as Dr. Harris said before, and also Reverend Dr. Boyer, they're essential workers. So they're busy out here trying to survive. And so some of those more routine services are being missed. And we know that. When we looked at the maternal mortality crisis in particular, we didn't just go to the table and say, listen, we're going to do this, this, and this. We actually polled the people. So what did that mean? We did a series of focus groups statewide and talked to Black and brown mothers about what are the issues? You know, is it about access to healthcare? Are you too busy? You get into prenatal care late? And they actually told us sometimes, but when we get to prenatal care, we don't feel like we're treated with respect. We have a lot of other compounding issues, jobs, transportation. I don't like the school my kids go to, stress, mental health. I'm afraid to say that I feel down because DCP&P may come and take my kids. We haven't had good experiences with some of these systems. And so I would say that access is certainly part of it, but it really is stress. What it came down to was that people needed social supports, and social supports for all people, all levels, cutting across socioeconomic status. It is stressful to be a Black person in America. It is stressful to be a Black person in New Jersey. And the stress on a Black mother in New Jersey makes her 4 to 5 times more likely not to survive childbirth, regardless of socioeconomic status. So sometimes when I do these talks, I often just want to say names. Shanice Wallace. Shanice Wallace. Let's give her a minute. About a week ago, chief pediatric resident, pregnant with her first baby, died in childbirth, died from preeclampsia, something that we know is a preventable condition, but something that we know is much more common in Black women. She is gone. And another child is expected to grow up without a mother from something that could be very preventable. I don't know the details. I don't know her story, but we hear too many stories like this. And we know that even your education and your pedigree does not necessarily protect you. So what is going on? Serena Williams was there. We all know who she is. If she told me something, I would listen to her, but there were still people who were refusing to listen to her. There is a problem. This creates stress. I have young daughters, nieces, who tell me, Auntie, you know, we worry about whenever we get to that stage, will we come out in what? These are concerns that are not just and are not acceptable. And so sort of laying out the landscape, what do we do then at the Department of Health? We went around, we collected the information, and it kept pointing back to these social supports that were missing. We came back to the drawing board and I said, we're going to pull this program apart. So we started with the data and we created a program that was directed at eliminating these disparities. So people said to me, is this just for Black women? It's for purple women. Whoever is suffering the worst, we must work, because when we improve the status for them, we'll improve it for everybody with whatever it is we're doing. Based on that, we developed initiatives really around social support. One of them was we trained a bunch of community-based doulas, Black and brown women who would go out in the community and help Black and brown women like themselves. We created this training. The demand was overwhelming. We have 80 warrior queens running the streets of New Jersey, supporting other women. And the outcomes have been fantabulous. Fantabulous, you know, a word that I make up, but we're so proud of them. Medicaid has come to the table, and so they will provide the sustainability in terms of funding. And so, you know, these things are possible. These things are possible, but I cannot stress enough, stress is real, and the stresses that we put on these communities does result in poorer outcomes. And pedigree, name, education, and all that does not protect you. So it is a fact. There's a lot of anti-racism training that must happen in the healthcare system and across all systems. We really need to be serious about health equity and ask ourselves to really stop and take a minute and say, you know, what is really happening? So we are also embarking on a series of implicit bias trainings in hospitals and FQHCs, and not hospitals just for clinicians, not just for the doc or the nurse, for the person that you meet at the admissions desk when you first walk in, the person that kind of looks at you from head to toe, rolls their eyes, and has an attitude as to how they want to admit you into the ER. So this training is going to go across the board for everybody. We're human. We all have some type of bias. It's part of being a human being. I might be biased towards, I don't know, older people, or I should say younger people, because I'm old. But we all have biases, and it's part of life. We just have to figure out how to unlearn and undo those biases. And so, you know, that's a program that we are working on. So a lot of issues, but a lot of solutions. And the very last thing I'll say is a lot of new partners. You know, part of the initiative we did around maternal mortality and infant health was to take the grant funding and demand that the key grantees work with non-traditional partners. And that was just not a partnership on paper. It was sub-grant, some of your grant dollars to an organization that doesn't look like you from a different arena so that you can begin to build the capacity of these community-based organizations. I love what Melissa and Dr. Harris talked about when they talked about the need to effectively engage the community. We will not be successful when we do this from Trenton. We will not be successful when we do this with all the same partners that we've been doing this with for years. We have to take the time and build capacity in the community at these community-based organizations, or nothing will change. Nothing will change. And so a lot of work to do, but a lot of exciting work to do, and a lot of partners. I think this COVID pandemic has just made it real, right? It's really made it real to everybody. And so a lot of discussion about implicit bias training across many different departments. We have a champion in the First Lady who is talking about maternal mortality and really pushing the envelope and making this the issue that it deserves to be. So we're excited, you know, we're encouraged. We're encouraged about what is ahead. And again, thrilled to be able to align with the work that you are doing here.
Thank you so much, Commissioner Asari. So, you know, thank you for lifting up Sharnice Wallace, because it's so frustrating, and it's really hard to digest that. Every time I come to the table for one of these kind of panels, sometimes I've been at one panel 3 weeks prior, and in between each panel, I can name one or two more Black mothers who died in childbirth. Every panel that I come to, we are able to lift up someone's name. And while it's important we lift them up, we don't want to keep being here. And so we know that there's still more work to be done. And I know that from the perspective as a state agency, you know, unfunded mandates render empty gestures to serious problems. Simply put, we know your office requires adequate funding to properly address the disparities in particular. What are the current measures or initiatives from your office to address these different disparities? But more so, what would optimal funding look like to best address these issues? Let's talk about funding of these different mandates and initiatives.
So $1 million question. I love this question. And I almost say, where do you start? Because people often ask me this type of question, and it's hard to answer. 401 years. We have a lot of unpacking to do. You know, how much is enough? I don't know if I would put a dollar amount on it, but I would actually say we should create a stream of equity funding across state departments. I like the commentary from the prophetic demands about making racial equity a must do, not an optional, we'll think about it or we'll squeeze it in. And from where I sit, I think some of the things that we're doing is really looking for equity indicators in our grant making process. What does your leadership look like? Who do you hire? Who's on your board? You can't do the work for the people if you don't have anybody on your team who understands what the people are experiencing. It's just not okay. You know, and so I think that the dollars are certainly part of it, but I think the structure and the accountability is more a part of it. So I say to my college age kids, it's not always how much money you have, It's how you manage what you have. And so maybe it's hard for me to sort of put a dollar figure on it, but I would say I would rather talk about the conditions that should go along with the funding, because I think we have money out in communities. We just need to pause and think about what we're doing and really move from data to action and make folks accountable. When I made the move to really insist that any grant that was associated with this Healthy Women, Healthy Families initiative had to have 10 to 15% of its dollar value go to a non-traditional partner, people were not happy because they're used to bringing me the partnerships, on paper. Look, we have this letter they signed, they're my partner. But they didn't want me to mess around in the accounts. That was a little bit too much. But what does a partnership mean? How will you effectively reach these people? The amount of money that we're giving you is designed to be shared. And what did they share the money to? They use it to hire community health workers. We just established a Community Health Worker Institute a couple of months ago. We stood it up. We had our first cohort of students launch this week, 43 students across the state who are willing to go out into the community and help their peers. Doing this through county colleges so that people can get a piece of paper that they can trade in for an associate's degree and potentially a bachelor's degree, really working on policy to establish minimum wages so that it's not like you pay them what you think you want to pay them. We're taking them through an organized training and certifying them so the pay should not go below a certain level. So, all of these are strategies. Sometimes it's new money and sometimes it's not. Sometimes it's the same money, but we repurpose it and really put benchmarks and some real accountability behind it. So, I wish I had the answer. I'm probably missing my opportunity to say what I need, but I think it's really about looking closely at what we have, who we're giving it to, and what the yield and return on those dollars is.
Exactly. You know what? I don't think you missed your moment at all. A lot of times it also has to do, like you said, you may have an allotted amount of money, but what your budget breakout is often reflective of the things that are important to you. So these things should be important and they should be reflective in how whatever money you do have is spent. And so I don't think you missed it at all. I think you put it back in perspective of how to effectively use your money. So with that being said, I just want to thank all of our panelists for participating in this formal session or formal discussion part of this event, but we're going to turn it over to the audience Q&A, and that will be led by Amber. I'm sure you'll pull from the chat box, and I'll turn it over to you.
Yes, thank you, Crystal. So the only question that we have in the chat box right now is from Erin, and this is directed to Commissioner Lisa. She just wanted to get some clarity around the doula project that you mentioned. Is it the project that is SPAN's Sister to Sister Doula project, or is there another program available in New Jersey?
So Erin, thank you for your question. And I'm glad you know about the SPAN Sister to Sister Doula. That is one of the 3 pilot projects. That pilot is in Newark in Essex County. There's another pilot, Doulas of Central Jersey, that is in Trenton. And the 3rd and final pilot is in Camden and Atlantic City called Community Doulas of South Jersey. There are 3 pilots that we funded about 2 years ago. So I feel like we're at maybe the 2.5-year mark. We have about 80 doulas that we have trained, but we really need more in the workforce. And so I will stay connected to this organization because we will be actively recruiting for more community-based doulas moving forward. Now that we have Medicaid at the table, it's no longer a pilot like what it was when we started, because they got deeper pockets than me, and they're here for the long term to provide this as a statewide benefit to women who are interested. But I encourage you to really share with your partners and your constituents, women helping women works. And so we don't see this as, we see this as an excellent investment and something that we're building upon. We're in conversations. We even have Economic Development Authority coming to us and asking us how they can partner with us on developing this workforce. So we are actually attracting attention from many, many non-traditional partners who see this as a solution by us, for us, but also see this as helping with the economics as well. So I see we don't have any in Union County yet, but coming soon. You know, we really are looking to make this a statewide benefit. Thank you.
Thank you, Commissioner. We have another question. Mr. Harris, could you please repeat the 3 pieces of legislation that were introduced but are not moving and need more support? That comes from our great partner, Laura, down at NGCA.
Okay, certainly will. And I'll just make a comment. 2021, the entire legislature and the governor is up for election. So it's very timely that we should take a look at converting the recommendations in this report to an agenda that we put in front of those people who will be seeking office moving forward. Just as a note, in 1989, there was a gubernatorial election. The Black Issues Convention and others made the creation of an Office of Minority Health an agenda item, got both of the gubernatorial candidates to commit to that, both the Republican and Democrat. That's how by 1991 we got the office. So I just point that out. So the one piece of legislation was by Assemblywoman McKnight, and I apologize, I don't have the bill number handy, that would declare racism a public health emergency in New Jersey. Another bill sponsored by Assemblywoman Savanda Sumter established a task force on COVID-19 racial equity. A companion piece of legislation would have created a racial equity officer for COVID and minority health disparities elimination. And there's also a bill, and I don't know who the sponsor is. We can look that up and get it to everyone. That established a requirement for implicit bias training for all health professionals. Those are 4 bills. None of those bills have moved, and I would suggest that in addition to the recommendations that are appropriate for state action, state legislative action, that's in the report, we add those as a combined agenda so we move forward and organize.
And then, Mr. Harris, I can follow up with you after this just to make sure we have all the bill numbers and everything, and then I can email it to all the participants.
Okay.
All right, so those are all the questions that I see in the chat. I invite our audience to continue submitting any additional questions or comments, or if you want to unmute yourself, I welcome you to do that at this time, or raise your hand and I can point you out. Yes, Sister Clara.
This question is for you, Lisa. The new training that you spoke about a few moments ago, are you looking for new partners, or will you be looking to maybe refund some of the consortia now because they're doing, so much education? Or are you looking for people that actually look like the people that we should be training?
Thanks, Clara, for that question. We are actually looking for new partners.
Good.
We have stood up a Community Health Worker Institute. You can apply and come as a CHW, or you can come as an employer partner. Because what we find is many community-based organizations do this with volunteers, and they shouldn't have to. And so we have set up this training institute that people can bring employees into. We got a grant from Department of Labor to do this using an apprenticeship program. So we can actually incentivize an employer. So if you're a church and you say, hey, I want to bring somebody in, train my CHW, we can incentivize to give you something to kind of partner with us. And so something we're really excited about, and I would be remiss if I didn't say we have named it after a colleague we lost to COVID-19.
Okay, great. That's wonderful.
Lamothe Gillette Institute, Community Health Worker Institute. And she was a public health champion, was actually a deputy commissioner at the Department of Health. And she passed,
right, I know her, I knew her.
the first week of April. Yeah, you know her, Clara, to complications from COVID. So we had and dedicated this institute in her honor because she was a real fighter.
Yes, she was. And my last question, Lisa, how will this go out into the community so the broad community would know that they may be able to, you know, participate? Because we do have a lot of people that are losing their jobs or lost already. So we would like to, you know, see that that is really put out, you know, so that people who normally will not see it. Because a lot of times we decide that people should have a computer so they can fill out something online, and maybe that person doesn't have a computer. So how are you all looking at getting all of those words out? Because I know tons of people that are not working that wish they could find a job.
So thank you for that question. We work with organizations like Salvation and Social Justice. We work with the NAACP. We are working with many different partners, but I'm available. You know, I'm available to share this information with you and really ask you all on this call to help me push this out. I can't get everywhere, but you all get a lot of places, right? And so many of the doulas, many of the CHWs also in turn push it out in their networks.
Okay,
so
we'd be happy to do.
Pandemic going on, but we still communicate. We're still talking.
Thank you so much, Lisa. Are there any other questions out there, Amber?
There's no other questions in the chat.
All right, did anyone else unmute themselves that has a question or comment?
Yes, I have a comment, Jackie Laportes. My comment is that I have a son that suffers from mental illness, and I tell the doctors that I'm refusing to bring him back because white doctors do not understand mental health in the Black community. They ask you the same old stupid questions all the time. And I get frustrated. And I tell them, well, I'm not going to bring my son back until we see a Black psychiatrist for him. And that's my biggest issue.
Thank you for that. What area are you in, by the way?
I live in Stratford, New Jersey.
Okay. You know, maybe something that I certainly wouldn't mind taking on under our health platform is trying to compile a list of Black providers, whether it's mental health or physical health. I wouldn't mind working on that. Now, of course, that wouldn't come with any, you know, I can't say recommendations on their level of care or anything like that, as I wouldn't be able to for any doctor, but at least it could be a resource that's out there so that you could find someone who looks like you, who might be in a better space to better assist your son. That's something we can start to work on sooner than later. Absolutely.
And Crystal, can I add to that as well? Sure, thank you so much for that. I really feel for what you and your son are having to experience. I mean, he's looking for help. You're looking for help for him, and it's just, I understand it gets really frustrating when you're talking to someone and they don't understand your lived experience. And often, you know, that happens within the mental health field. I mean, very well-meaning therapists will, because of their own lens and their own personal experiences, unfortunately, not be able to hear what's not being said. You know, they're not really listening to what is going on in front of them because they don't have the bandwidth, not bandwidth, I'm sorry, it's the wrong way to put it, context to properly understand it. So that's why we're challenging ourselves at a center to continue to expand the number of Black therapists we have and therapists of color. And I know that there are a couple of other places out there that actually do. There's one in particular that I'm thinking of. It's a little bit small, but all of their therapists are Black. So, and I was going to partner with them because that's hard to find.
Well,
yes.
Well,
I'm sorry.
That's one thing that I was worried. See, I'm an EMT for the state of New Jersey, but I work for a private company. But what it is, I try to tell them, no, my son is going to beat this thing. You're not going to put him on all these different types of medications. Because I go online and I look up the different medications that they give them, and I'll be like, oh no, and it say that you may have thoughts of suicide and all this other stuff. You may have hemorrhaging, you may be bleeding. I'll be like, nah, my son don't need that stuff. They don't understand that you just can't medicate a child and expect for me as a parent to sit back, because I'm the best advocate for my son. And I'm going to continue to advocate for my son. I mean, the doctors hate to see me coming, because they know if it ain't right, it ain't going to fly with me. I don't play that.
That's right. That's what you should be doing. I applaud you for that, advocating for your son, because too often, and there are statistics and reports that show this, our kids tend to be over medicated when it comes to mental health concerns. So that is wonderful that you're advocating for him. But Crystal, what I'll do is I'll look up the name of that therapist, and as you're creating your list, I'll share that with you so that you can
appreciate that.
Thank you, sir.
You know, I try to tell people mental health is nothing to be ashamed of. You know, it's just the way that you go about it. And I see some other parents out here, I talk to them and I tell them, well, why don't you try to come on these websites with me to these Zoom meetings and stuff? Because mental health is something that we have no control over, but we do have the ability to fix it as parents. If you're speaking up for yourself, you can speak up for your child, because your child is precious to you. And that's what I refuse to allow anybody to tell me anything different about my son, because I know better. You understand? Mental health can be beat. And you're not just going to sit here and load my son up with all types of, have him taking medication 3 times a day. Oh, no, that's out of the question. That's out of the question.
That's right.
That's right. Thank you so much. And I'm sure your son appreciates your advocacy on his behalf. We definitely have to remove the stigmatization from mental health. It's just not necessary. We don't have to be. It's not something to be ashamed of, but it's something that we can deal with. And when we start talking about it openly, then we can start to strategize against situations like that, where they're looking to just medicate us and not have any other kind of creative ways to deal with the different things that we're trying to get over or get through. So I thank you for lifting that up. Anybody else before we go into our closing remarks? This has been great. All right. So I just want to thank everybody for coming into this space with us tonight to talk about something that is so important, health. We are here, to televise this health revolution. We are here to start to undo 401 years of damage, of breaking the backs of Black people in this country, and certainly starting right here in New Jersey. So, we couldn't have had a more of a dream team for the panelists tonight. So I thank each and every one of you. You all brought some invaluable information to this discussion. And what we ask as far as this call to action, like Lisa pointed out, Commissioner Asari pointed out, is that we need you to get the word out as well. All of our panelists can't be everywhere, but you now know some people who you can get some information to, and that's how you start to be a part of this revolution. It's going to take all of us to get this work done. So again, the things you got here tonight, please, please, please share with your friends, share with your coworkers, share with your frenemies, share with everyone, right? Because, this dialogue has to become open, because we have to talk to the people who really don't care about it in the first place in order to make some change, right? They too have to be at the table. And so now everybody here has been deputized as ambassadors for this revolution. So don't think you came here with the opportunity just to receive information, but you came here, actually we kind of just lured you in so that we can put you out into the world to help fight this with us. And so we got you. And we thank you in advance for what you're going to do. And so, please definitely follow us on social media, because we will always try to keep that with an abundance of information that will benefit everyone in the health space and all the other areas that Salvation and Social Justice is championing. So with that being said, I'm going to turn it over to Amber. Thank you, Amber, for getting us up and running, having us streaming live. I mean, you can't do anything without your good communications team. So I have to lift up Amber, and I thank specifically, again, our panel members, our foundation members, for participating this evening. Clara, we thank you. Chairman Harris, we thank you. Commissioner Asari, Ms. Fox, we thank you all. And, I know we've all said your name several times and, we've heard it all night, but it's important to acknowledge people as individuals when they're all coming together as a collective to do great work, right? So thank you all once again. And with that, I'll turn it over to Amber. We're gonna wrap this thing up.
We're gonna wrap it up. Thank you so much, Crystal. I echo everything that you said. Really, this was phenomenal. And I loved it because we were really able to get into so many tangible things where we can really start making change. I know we do a lot of different panels and everything like that, but I truly believe that justice starts with having equitable health for everybody. So this really just warms my heart to be able to dialogue around this. So just a few other announcements. I see that there were a few different members of our board of directors who are present today. So I just wanted to take a second to just acknowledge all of our board of directors. So as we know, Mr. Harris, our chairman, Sister Clara Gregory, our vice president of Salvation and Social Justice board of directors. We have Francis Harwell, who is the secretary, Mr. Willie Moore, who's the chaplain, Sister Loretta Winters, Kim Wellens, Tracy D. Syfax, Deborah Jennings, and Hosea Johnson. I just wanted to take a second to uplift our wonderful board because truly all of the work and support that you all provide to all the work that we do across all the verticals at SNSJ is truly appreciated. And then real quick, and then I will let you all go and get ready to, I'm sure you're about to go eat dinner and whatnot. There's just a few action items that I wanted to lift up. Give me 1 second. So, we got to do some action items before we get off the panel. So one, just want to re-emphasize, right, the 10 takeaways that we have as a part of the report. 1, to enact universal health care immediately. 2, prioritize Black maternal health. 3, integrate healthcare. The Office for Civil Rights must enforce Title VI compliance. And 4, divest militarization and criminalization and invest in mental health care and community wellness. 5, transform the use of healthcare to include the social determinants. 6, adequately fund and empower the Office of Minority and Multicultural Health. 7, establish adequate accessible preventative care in Black communities. 8, mandate racial impact statements for all healthcare legislation. 9, provide accessible testing centers across the state. And then last but not least, 10, ensure we have uniform methods of data collection. And then the last, one of the last announcements I have for you all is November 5th, please register. We are going to be doing a virtual training for faith and community-based organizations who want to know more about the Affordable Care Act and open enrollment. Open enrollment begins November 1st. So we want to make sure that our communities are well equipped to take advantage of that. So that is on November 1st or November 5th. Please register. The information is here on the screen. I'll put the link in the chat in a second. And then last but not least, I just want to reemphasize, a few people have already mentioned it, but please just go out and vote. We are so close. Wow, it's hard to believe that we're only a few days away from Election Day. So we are so close to the finish line. I encourage you to exercise this right that so many of our ancestors have sacrificed themselves for. Go out, please vote, make your voice heard. And with that, the last voice that we will hear tonight is Mr. Jerry Harris. I turn it over to you just to do the final wrap up.
Okay, thank you. And I want to thank all the panelists, all the participants for what has in fact been an invigorating, exciting, new beginning to the next phase of our struggle to transform our communities from a health perspective. We must reimagine the world as we would see it. We must become the change we want to see. The Salvation and Social Justice believes in liberation through theology. We ask you to embrace that, join us. I'm drawn to the words of the last stanza of lift every voice and sing, God of our weary years, God of our silent tears, thou hast brought us thus far along the way. Thou who is by thy might, let us into the light, keep us forever in their path, we pray. Bless our feet straight from the places, our God, where we met thee. Bless our minds, drunk with the wine of the world, we forget thee. Shadowed beneath thy hand, may we forever stand, true to our God, true to our native land. Good night and God bless.
God bless everyone. Take care.
Thank you again, everyone. Thank you for everything, Amber.